Hello, everyone. I am very glad to welcome you to the third AI4Health chair. Okay. My name is Giovanni Briganti. I'm the AI4Health lead at AI4Belgium. Just to recall, the AI4Health chair is a series of webinars taking place in 2022, where we showcase concrete hospital projects or concrete healthcare-based projects in which AI, digital health, and digital ecosystem are actually impacting patient care. So we want to showcase concrete projects instead of talking about theoretical stuff. Today's event is a bit special, not only because we are in the AI4Health track and we are in the European AI Week, but because the subject is pretty specific. It is focused on clinical decision support. And to talk to you about clinical decision support, we took a very special speaker. Today's speaker, Olivier Lemoine, is a professor of medical informatics at Université Libre de Bruxelles. It is associate medical director for medical informatics at Hôpital Erasme, the university's academic hospital. And he was my professor once. He introduced me to the world of academic and medical informatics, and he is the one who inspired me the passion for medical informatics. Olivier has led a brilliant career. He has published extensively on the topics of medicine, gastroenterology, medical informatics, and is a widely recognized expert in the field of medical terminology, medical informatics, and clinical decision support. So it is my enormous pleasure to present to you Olivier Lemoine. Olivier, the floor is yours.
Thank you so much for this very kind introduction, Mr. Chairman. So, as you saw, we will discuss about a clinical decision support for about 30 minutes. Where we come from and where do we go. The major aim of this topic is to provide you a holistic view of from where we come and where do we go. So perhaps the first thing to discuss is what is clinical decision support in healthcare. So it's kind of function and tool that provide access to medical literature and evidence-based medicine, help for prevention of disease, screening, vaccination, prediction, genetic background, help to make an adequate diagnosis and treatment plan for a given patient, and deliver warnings in accordance to elements of the patient charts concerning especially drug interactions, allergies, comorbidities. In fact, it's basically like our brain functions and our computer work. It is rule-based. On an event occurring in the EMR, for example, electronic medical record, on an event, if a condition is there, then you have an action or else another action. This is the basic principle. So to give you very simple examples of clinical decision support, on an encounter with a patient, if whatever the discipline or the specialty of the doctor, if the patient has more than 30 years and has an history of family history of female breast cancer, then you refer the patient to breast screening program. Another simple example is on publishing of blood potassium results, for example, because you asked for potassium in a blood sampling. If in the EHR electronic health record you have chest pain, which is coded, and if the patient has digoxin for an active treatment, and that the result of the potassium is less than 3 millimoles, then it is an emergency and you have to page the attending physician. These are simple examples. So how it works, the clinical decision support. You have 5 different functions. The first one is the knowledge database. This means all the knowledge available in the world, let's say. You have the inference engine, which is the if, then, else. You have the terminology services, and terminology services are especially talking to the inference engine and to the patient charts. So it's the same language, and there is a kind of interoperability in between the patient charts and the inference engine. And finally, you have the communication services. This means how, if the inference engine finds something to do, or it communicated to different persons. So that's the 5 functions, and we will see for each time those 5 functions. So we will go to where we come from, where we stand today, and where we go, hopefully soon. Where we come from. When I began my graduating in medicine about 30 years ago, this was where I was confronted. And the knowledge database were books, articles, conferences, and this is a picture of the Index Medicus, 1 volume per month for many, many, many years. You can imagine that it's taking a lot of place into a library and university library. And those who were interested in some diseases or drugs or something like this could find into these books the articles that were published recently about the subject and the abstract. Afterwards, you had to ask to the librarian to make photocopies if possible. If not, ask to another university, and this took sometimes weeks to obtain a paper article. That's knowledge at that time. The inference engine was definitely in the brain of the doctor. And this is important because he's managing all the knowledge and the communication and so on. Concerning the terminology services, it's something what the doctors like. Acronyms and eponyms, the more ununderstandable it is, the more they like it. And you have 3 examples here to translate allergy to iodine products. It might be AI. It's why I put a smiley over there, or IA. or al I, or al I with a space, or allergy with a typo to iodine. Other example, ankylosing spondylitis, AS, Becherud disease, Marie-Strumpel spondylitis, spondylosis deformans, and even inside different specialties of medicine, the same acronym, for example, PID, represent pelvic inflammatory disease for gynecologists, but pneumopathy in interstitial disease for pneumologists. So this is the summary of that, of those terminology services at that time. These are unstructured data. They are ununderstandable sometimes or unreadable sometimes. Concerning patient charts, there were many bookshelves in the archives of the hospital at that time, and this was the patient charts with different classifications inside by specialty or by examination, by procedures, and so on. Finally, communication services were either handwritten, like you see on the left, or more modern typing and then post to ensure communication. So if we can summarize where we come from, is the knowledge database was inside of the brain of the doctor, the inference engine inside of the brain of the doctor, terminology services inside of the brain of the doctor, patient charts were in fact paper, and communication was also paper. So, clinical decision support, where we stand today. In between 30 years ago and now, technology has exploded with internet, search engines, computer power, Moore's law. This means that the power of the microprocessors are doubling each 18 months with the same price. Mobile technology, smartphones, and communication 2G to 5G, Internet of Things, your Apple Watch, for example, cloud computing, and robotics, and many other things. So that's what changed comparing to 30 years ago. And during those 30 years, there are new paradigms that appeared in healthcare. And this picture is quite explainable. You see from 1917 to 2020, it changed a lot. And we have to deal now with more elderly patients and chronic diseases, less caregivers, patient-centric and personalized medicine, which is time-consuming, budget constraints, increased costs, and administrative burden. So see the difference between 70s and 2020. So to solve this equation, the main thing is save time in healthcare for the patient. And if you are interested, you can buy this book from Marc Britnell, published in 19. And this guy flew around the world to see all the healthcare systems, and is doing a summary in this book. And he's convinced that we can save about 20% of her time by doing what you see on the left: digitalization, robotization of administrative and logistic processes, digitalization of patient charts and help with clinical decision support, intelligent integration of IoTs and mobile apps, implementation of global interoperability with semantic structured data, technical interoperability, and procedures like patient pathways. Concerning semantic interoperability, this means structured data, standard terminologies. I will not go into details here, but SNOMED CT, managed by SNOMED International, is a worldwide used medical terminology with very granular description, which are used by a clinician all around the world. A simple example of that, each concept of a SNOMED CT, this means a clinical meaning, has only one code to be shared. And here you can see that the same code has been translated in different languages: French, US, polyp of colon, Greek, Arabic, and the procedure to remove a polyp from the colon, it's exactly the same. So if the patient is bringing his code in any country, the doctor in any country will understand what it means. So technical interoperability is now standardized worldwide again, and it's through HL7 Fire Foundation. One important point is that we talked about interoperability, and we can imagine that the fact that we have digital records in our EHR and so on might lead to interoperability. And if you remember the Obamacare, there were billions of incentives given to hospitals and situation of cares to implement EHRs, And you see that's quite efficient with these incentives. About 80% of the hospitals were had electronic health records in 2015. However, the major problem is that those EHRs, only 40% were able to give interoperability between different hospitals, and only 18% of those 40% used really interoperability. So it's the reason why EHR implementation is only half of the battle. What are the benefits of a clinical decision support system? We know that approximately 10% of patients are harmed by adverse events during their hospitalization or in primary care. And adverse drug events are the most frequent ones. Adverse drug events are associated with increased hospital stay, additional costs, and mortality, thinking that actual numbers are probably underestimated. And about 30% of adverse drug events are considered to be preventable by adequate CDSS, and even 56% for allergies. So it's very important to have a clinical decision support system. Concerning the knowledge databases today, and it's certainly not exhaustive, we have a lot from internet, which are international, like PubMed Medline, Embase, Cochrane, UpToDate. And you need also some knowledge databases at the national level concerning regulation and language. And these are examples for Belgium concerning drugs, for example, and web services also, which are rule-based information, if then else, and those are examples of Belgium also. Concerning the inference engine today, as I said, it's computer-based now, based on rule-based algorithms, very simple, like to see on the right. If it's possible to make a pancake using homemade databases with structured data, this is very important again, structured data, using web services from a provider with structured data again, and also using structured data from the EHR for a dedicated patient. So concerning terminology services, today, we already talked about SNOMED CT, and there are others using around the world, but which are ICD-10, for example, and ICPC2 for primary care, but those are really less granular to be used in clinical practice as compared to SNOMED CT. Most of the patient charts today are electronic health records, EHR or EMR, and communication services and interoperability are based on the response of inference module. This means they can warn the clinician of some incompatibilities or some warning to be considered. And I have two simple examples here. I apologize, it's in French, but you have a benign hyperplasia of the prostate encoded in your EMR. This is a structured code in SNOMED CT. And then the inference engine has detected that there is a contraindication when you plan to prescribe Buscopan. And if you go to details, it's because it may lead to urinary retention. Same for allergy to penicillin. Again, structured data in SNOMED here. And I will not prescribe penicillin, but I will prescribe a cephalosporin, which is another class of antibiotics. But we well know that there is a cross reaction between cephalosporin and penicillin for allergies. So when I try to prescribe a cephalosporin, I got a warning because there is a cross reaction with penicillin. Currently, at least in Belgium, national interoperability is still based on sharing non-structured data, mainly PDF documents. So, to summarize again, the knowledge database today is mainly internet-based or through cloud web services. The inference engine is rule-based, computerized algorithms. Terminology services are standardized terminologies. The patient charts and communication and interoperability modules are computerized. So there are some drawbacks of these systems today. And those drawbacks are, it's three points. First, the past unstructured data, for example, on paper or something like this, are not used unless huge human efforts. The maintenance of the inference engine and the terminology services is important, and we have to take that into account. And finally, there is what we call the alerts fatigue. And these alerts fatigue lead to override of the warnings for different reasons and may lead to burnout. So if you can imagine having those kind of alerts each time you want to prescribe a drug, this is really fatigue at a certain time. So this was the situation today. What can we expect for the future? Where do we go? If you look at the scientific literature on PubMed Medline, and you search for clinical decision support and artificial intelligence, and you see the number of articles growing exponentially within the 5 last years. And this means that AI is taking more and more importance in the setting of clinical decision support. I like this picture because it's extremely important. And AI, even if it is another brain, let's say, it's still in the end of the human. And the human has control to AI, and AI aims to enhance human capabilities under the control of humans. This is very important. So I will give you one example because it's the AI concerning the IBM Watson Oncology, which was released in 2015. And therefore we have some years of experience and of scientific publications concerning this AI, which aimed at a global AI system in oncology. And it was aiming to help oncologists worldwide in diagnosis, treatment, clinical decision support, and follow-up of patients with malignant tumors. The system was fed with all world cancer literature and clinical data from thousands of cases of the Memorial Sloan Kettering in New York. During this time, from 2015, only 9 studies had sufficient power to compare Watson's recommendations with those of clinician teams, multidisciplinary clinician teams. Overall, the results were quite good, with 84% of concordance between Watson and multidisciplinary teams. However, it varied according to cancer type and tumor staging, meaning that there was a kind of heterogeneity in between those studies. So the main question for clinician was, what are the advantages and disadvantages of such a system? The advantages are Watson can improve doctors' efficiency and reduce workload. It was estimated to be about 8 minutes per case. Watson can prevent man-made calculation errors, which can be fatal in case of antineoplastic drugs. Watson can improve the quality of doctor-patient communication because they have much more time. And Watson can improve the professional level of young clinicians. I think this is something very important. And also there is an auto-update of knowledge databases. The disadvantages of such a system was a significant decrease in consistency with advanced cancer. Also, a difference in consistency between countries, and especially because there is a difference in sensitivity and tolerance to specific chemotherapies, for example, in between Caucasian and Chinese people. The same for epidemiology of tumors and surgical treatments adopted for those tumors. For example, gastric cancer at low consistency, and this is related to the fact that there is a huge number of gastric cancers in Asia, while it is a kind of, let's say, more rare cancer in the Occident. Also, as its real-time recommendations, for example, in case of transient renal failure, which can be solved within 1 week, for example, the adequate chemotherapy for this patient would be discarded. However, after treatment of the renal failure, it can be applied. So this is also something. And also we have differences into the availability and costs and reimbursement of drugs, which can be different in different countries. What can we expect from AI for clinical decision support systems? And again, it's not exhaustive. These are only examples. And again, about the 5 functions, knowledge database, we can expect integration and structuration of many scientific resources, including rare diseases and genetics, for example. For the inference engine, machine learning instead of rule-based algorithm might certainly help in prediction, for example, therapeutic response and optimal medication dosage. For terminology services, integration of multiple structured resources. And concerning patient charts, this is one of the important points. We can structure data, unstructured data with natural language processing and also with voice recognition. Collection of data before encounter and help for diagnosis. We had an example in the previous session with Bingley. Integration of data from IoTs It's also very important, it's not yet the case in many clinical decision supports in the world, and communication and interoperability services. And this is very important because here we have a huge room to tailor alerts to users. And machine learning, it was shown that it can increase the relevance to 85%, the relevance of alerts versus 16% for rule-based algorithms, and decrease the alert rate very significantly. So these are some of the ways AI might enhance and improve the CDSS. So that if we summarize again concerning the 5 functions, now each of those functions, knowledge database, inference engine, terminology services, patient charts, and communication and interoperability might benefit from AI, controlled AI by humans. So to summarize, Mr. Chairman and dear colleagues, there is still room to improve and generalize current CDSS systems, which are rule-based algorithms in healthcare EHRs. And I insist on the fact that it should be generalized because it's not yet implemented everywhere. AI, through machine learning, will dramatically improve clinical decision support system in healthcare if we place ourselves in an innovative centric view and provide time savings. However, there are some drawbacks that should be addressed before a widespread use of AI, and this is much more a service-centric view. And these drawbacks are we need to validate the technological solutions in clinical practice by adequate scientific studies. We have to take into account and certainly correct the datasets biases, which are the basis of machine learning, and especially concerning geographic specificities. There are a lot of questions to be addressed concerning liability, regulations, ethics, accountability, and cybersecurity. And the end of the message is to make gain of confidence to healthcare givers and patients. AI as a complementary tool, human is still on the loop. I thank you very much for your attention.
Thank you so much, Olivier, for the incredible explanation about how clinical decision support systems work and how they may be implied into hospital systems to improve patient care and to gain confidence, as you say, of healthcare givers and patients. As the questions will come from the audience, I have one first questions for you, because all of this it is a very integrative introduction, but we know that you did all this and you had the experience of implementing all this stuff yourself in a hospital as a doctor, and it's a pretty unique experience at that you had. How are clinical decision support systems perceived by physicians you work with? Are physicians likely to be implied into the improvement of such systems? When I'm talking about clinical decision support system, I refer to the whole of EHR and terminology at Hôpital Erasme. Because I know that you made a very interesting initiative called the Medical IT Committee. How does it work? Do you have any insight to share?
Yes, I think that the implementation of such a system, the most difficult point is initially technical first, and it's more easy if you use terminologies like SNOMED CT, because you have many hierarchies and you can play with those and always find technical solutions. The other problem is the adoption by the physicians. And the adoption from the physicians, it's, let's say, on the base, the very basic point is that if they do not adopt structured data encoding, like in SNOMED, the clinical decision support will not work. So the first very difficult thing we were faced from 2015 compared to handwritten or any or free text in the AHS is to make this adoption of the structured encoding. And I am convinced that what we are doing together, Giovanni, let's say the teaching of informatics, medical informatics in the faculty, is going to make this adoption more easy, especially if the young students are coming with, have understood that interoperability and structuration is fundamental to work adequately in those systems. And well, the last thing I will say is the most difficult part, to make the adoption of structured data. This is not in the way of thinking of doctors. They are always unique in the world and cannot accept to encode a standardized structured data.
Yeah, I find the same. I find the same thing as you. That is convincing medical doctors while they are in clinical duties to encode given information into the electronic health record is difficult. But on the other way, we can use AI tools, and we know that in Belgium we do have solutions that automatically encode what is being inputted by the doctor, and such as early tracks in that we have in Belgium, which is a spin-off from UC Louvain that can encode well, terminology terms based on natural language using NLP, therefore, and I find it to be really interesting, because we can circumvent the kind of weakness that doctors have and still have encoded data. Of course, we should be directed towards structured terminology and choose a terminology once and for all Belgium, and we know that SNOMED City is the best candidate for that, so that we can actually achieve structured data and do clinical decision support, as you're doing, and you have been doing it at Hôpital Erasme for some years now. We had a really interesting audience. I see that people among the audience, we were having quite a bit of people across YouTube and Zoom that are following us, and we have engineers, medical doctors, medical directors, and I hope this message helped us show them what can be achieved while structuring data, while using this. So if people all around, if you do have some questions, please not hesitate to ask. We still have a few minutes. If not, I really want to thank you all for participating into this third AI4Health chair. I want to say a big thanks to Professor Olivier Lemoine for joining us for the clinical decision support session today. And Olivier will participate into an additional event of the European AI Week, who will take place on Saturday. That is a webinar on artificial intelligence and in medicine, where we'll trace back what we did at Université de Bruxelles in teaching students on how to approach IT, digital health, and so on, and discuss about the impact that has had in the last 5 years. And so you're welcome to join us for that additional webinar as well. Olivier will also serve on the steering committee of the upcoming University Certificate of Artificial Intelligence and Digital Health that will start in September 2022. Yeah, I'm really glad that we have had this collaboration going for quite a few years now. Thank you all. Thank you, Olivier, for joining us. And you can find the video on YouTube for playing it once more again. And we are able to wish you a very good night and a very good end of the European AI Week. Bye-bye.
Bye-bye. Thank you very much.